Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Great, thanks, Brian. I'm not going to talk about hepatitis B or hepatitis C today, but I'm kind of coming to you guys today wearing my hat as Medical Director for Digital Health. So over the summer, I was giving a series of lectures to folks in the Mountain West AETC and wanted to kind of take the highlights of some of those talks and share them with you. So this is more of the traditional face-to-face, one-on-one telemedicine we're talking about today, not Project Echo. So what I would like to do is start off with two poll questions. So Adrienne, if you wouldn't mind pulling up the first one, ask you guys to respond. Just kind of give a little pulse check here on your experience with telemedicine. The first question: before COVID-19, my clinic or hospital where I worked provided live synchronous video visits. Let's click agree or disagree, yes or no. All right, thanks. So interesting. So I see it looks like a majority of you were not offering live synchronous telemedicine before COVID-19. So why don't we close that survey and go to the next question, Adrienne? And so the question is, since COVID-19, so say starting in March or anytime until last week, have you started to provide live synchronous video visits? And if you were one of those 16% who said you were already doing it, I guess you'd just say agree since you're doing it again. Oh, wow. So pretty big switch there. Thanks, Adrienne. So looks like about 84% of you were not doing it. Now 100% of you guys are doing it now. So that's really helpful. So just a quick disclosure, not relevant to my talk today, but I over-disclose. So I just have two very simple objectives. The first is to list best practices for documentation during a telemedicine visit, since I get a lot of questions about that. And then getting a lot of questions about health disparities in telemedicine, and just want to share some strategies, how we can improve, and hopefully have a little bit of discussion if you guys have some experience and want to share your expertise in that area. That'd be great. So first of all, I just want to talk about a little bit of guidance on what's appropriate for telemedicine and what's not. And this is just kind of based on our experience at UW Medicine. We've done over 100,000 face-to-face telemedicine visits since January 1st. So about a 100-fold increase since we started with the epidemic. And so I think in general, we can give advice that follow-up of chronic conditions like mental health, things like high blood pressure, diabetes, obesity, and COPD. And I think that HIV for a lot of our patients are stable on their medications and undetectable with a good CD4 count, which will also fall in that category. In the liver clinic where I work, I also have used it for discussion of test results. So in particular, labs and imaging. And this is where using the share screen function, if you have that on your platform, is really useful so patients can kind of see the trend of their labs. And a lot of times I'm sharing the actual images of the ultrasound, and I can point out the areas that are of concern, or if there's any questions on that. Good use case would be counseling about diagnostic or therapeutic options. And then dermatology in general, both new and established patients seem to be very well suited for telemedicine. So moving on to maybe not so good use cases, and I'd say you kind of have to play it on a case-by-case basis, but obviously anything that requires a procedure, so a simple IND or anoscopy or something like that you're going to have to do that in person. Abdominal pain and gynecologic complaints I put on there just because sometimes you really just need to lay hands on the patient and get a sense for where their tenderness is, or you're doing them a little bit more of a detailed examination. Eye complaints, kind of similar issue. We have very specialized equipment for looking at the eye, slit lamp exam, and even just a good retinal exam. It's pretty hard to do through telemedicine. And then the last two areas are kind of a little bit more nebulous, but if you have a patient who has very highly nuanced care or a lot of complex conditions, sometimes you just need to be able to coordinate with folks in person, or a lot of times you're doing follow-up testing that needs to be done that day. And then the last situation would be any situation where your physical exam would change your recommendation or treatment plan. So I wanted to change gears and talk about some of the changes in Medicare telemedicine reimbursement. In the cartoon here has a picture of a patient and a doctor both in their boxers saying, man, this telemedicine thing is great. I don't even have to put my pants on. I thought that was a funny cartoon. So what Medicare did is they temporarily, and no, that's in italics there, removed some of the major restrictions. So those restrictions included that the patient had to be in a rural or a medically underserved area, and the patient could not be at home. They said for the duration of the public health emergency, you can be in an urban area, you can be in your home. Now, the public health emergency is in effect until October 24th. And after that, we really don't know what's going to happen. But the policies can only be changed by Congress. So this will literally require an act of Congress to make them permanent. They said it's okay for established or new patients, not just MDs and APPs, but a whole list of ancillary support staff like PT, OT, speech therapists, pharmacists. So it's really opened up. For those of you who work with residents and they are doing primary care, the attendings don't need to be in clinic. They can be joining by telemedicine from their own home, and the clinician can do from their home. So this is explicitly stated by Medicare. And if you have any questions, there's a good link from the American Telemedicine Association, and you can follow that for more information. Documentation is going to be about 90-95% similar to what you do in a normal ambulatory visit. The HPI and their background history. The changes get a little bit different with the physical exam. So first thing is the vital signs. We ask our patients ahead of the visit to get a thermometer and a flashlight. The thermometer is to get a temperature, and if they have a scale, that's often good. We ask them if they have blood pressure or way to measure pulse oximetries. Those are a little bit more fancy, but if they have those, there is a way to put those in, and you just say these are patient generated data. And then sometimes you do a lot of the physical exam, but sometimes the patients can kind of help you with the physical exam. So example, if you want to do a sinus exam, you'd have them push right here, see if they feel any lumps or bumps. And I do a lot of abdominal exams virtually. I ask them to kind of feel underneath the rib cages and see if it's tender there. I'll have them jump up and down, just to make sure there's no kind of serious, like acute abdomen kind of symptoms. But there's quite a bit you can get just from a visual inspection, as well as some guided self-examination. So then at the end of your note, we recommend the following text. So I conducted this encounter from where you are. And if you're at home, you just say my home. You don't need to put in your actual address. Comment about this being secure. And then the patient was either located at their home, located at their work. And if there was anyone else present, say a spouse or a family member, it's often good to have that documented as well. And then make sure that you document that consent was obtained. And so the consent does not need to be written, but you need to discuss before the visit kind of the risks and benefits of it. So I say, if I talk about the security of the platform, I talk about the fact that I can't really lay my hands on it, and then if there's something concerning, we might need to refer them for in-person care, and always give them the option to stop the visit at that time and get an in-person visit if that's appropriate. So when things were a little bit more serious with COVID-19, we had more providers doing this kind of triage where the patient was in the clinic, the doctor's in the clinic, but they didn't have PPE. So we're doing these kind of telemedicine visits within the clinic, and this is some documentation that we used at that time. I think with better access to PPE, we're not seeing this as much. So I mentioned this a little bit on that last slide, but be aware that some states require written consent. I'm not familiar with any of our Northwest states requiring that. I certainly don't need it in Washington state. And this is some of the things that we recommend folks talk about. Okay, so how do you bill? So in general, you're going to use your outpatient codes. So it's usually going to be your 99212s to 215s. Those are established. And then the 202s to 205s are new. And you can document on time. Now, the little wrinkle here is it's not what we're used to with time. So usually we say it's only that face-to-face time, and more than half has to be in counseling or coordination of care. Medicare has said it's total time. So that includes any kind of pre-visit review, includes the face-to-face time, and then actually any documentation or coordination of care that happens after the visit. So this is an example of a recent patient I saw. I spent 32 minutes with chart review, face-to-face time, documentation, coordinated care. So that got me up to a 214. You can also bill based on medical decision making. You have to have all those elements, both in the history and the complexity of care. And then at least at UW Medicine, we're recommending using the GT modifier for everyone, just because that's the most commonly used modifier. You'll see some payers might want a POS 2 or 95, but that really helps the coders if you put that GT modifier on there. Now, if you're not billing on total time and you're doing like a medical decision making, you can also use a Q3014 facility fee code. And it's pretty modest for like Medicare. It's about $26, $27. So we've really been going more towards the total time and not doing the facility fee. And then the last thing is, you guys probably know this, is that during the public health emergency, Medicare has agreed to pay for phone only or audio only visits at the same rate as telehealth and in-person visits. The latest physician fee schedule said that they're going to go do away with that. So I think that's an important issue to be aware of. And then these are the phone only codes, 99441 through 443. And I don't know how they're doing it, because you see that the time segments are different for like a 441 compared to 213. So I'm not sure how that conversion is working. I apologize if that's not totally clear. Billing is not my expertise. So I wanted to spend the next couple of slides talking about workflows, because this is super important. And hopefully this is something that you've got a little bit of experience with, but there might be some opportunities to improve this and optimize it. So a couple of tips. First of all, you need to ask yourself whether you're going to have one standard workflow or you're going to kind of have it different for different clinical areas and different clinicians. In general, we'd really like to standardize things as much as we can, just because we've got support staff that are coming and going and flexing from different areas. And it's just helpful to have a consistent process. Make sure everyone knows their role and their responsibility, like who's checking in, who's making sure they're checked out. Is it going to be the clinicians or is it going to be front desk staff? And, just make sure you're working with your billing department on that. Make sure you've got good support documents. So at UW, we've got a variety of things, some printed material. We made some videos kind of walking through how to use Zoom and how to use it with Epic and, clicking here and things like that. It's great to have a clinical champion if you can. And the most important thing is to test before you go live. Sounds like a lot of you guys are already live, but if you're kind of moving into a different clinic or you got a new provider, make sure that their first visit is not high stakes and just to have a test patient or 2 or 3. And then just make sure where everyone knows to find those documents. So some of the things you can do before the visit: make sure that before you schedule them, that they actually have the equipment to do a telemedicine visit. So before they get scheduled, ask them, do you have broadband? Do you have a device? Do you feel comfortable doing this? Do you feel like this is appropriate? And so that needs to be worked out with your front desk. And when you're scheduling it, make sure you have real clear guidelines and how to use the technology. For us at Harborview, we have a lot of non-English speaking patients. So, make sure you're coordinating with your interpreter services, and also make sure they have a good callback number if there's any kind of issues. So one of the best practices is to call the patients and get them online, get them hooked up at least 15 to 30 minutes before the appointment. For patients who are first appointment in the morning, like 8 o'clock, we're asking that they do the testing at like 4 or 4:30 the day before, just because a lot of our staff is kind of coming in right at 7:45, 7:50 and don't have quite that time to get those patients ready. So this is an example of the text that we send. We use a service called ZipWhip. It's HIPAA compliant, and you can kind of customize it. It has some links and job aids in there. Make sure it's at a sixth grade reading level. You could put this in different languages, things like that. So on the day of the visit, just make sure you know who's checking them in, and make sure there's a clear process on handoff. The latest thing what we've seen is people waiting for a long time on the platform. And just like if they were in person and they were sitting in their exam room for 15, 20 minutes, they're kind of wondering what's going on. So our recommendation is that you check in on them every 10, 15 minutes, just so they know if the provider's running late and there's not a technical issue. The other thing is we really want to have a good callback number. We've had a couple of patients get hypoglycemic and pass out during a telemedicine visit. There have been reports of patients who were suicidal and we needed to call 911. So make sure you've got a good callback number, you know where they are so that you can direct emergency personnel. And then just, make sure you got that whole handoff squared away with your various staff members. So a question I get a lot on is practicing telemedicine across state lines. And I apologize in advance, this is a gray area. It used to be much more black and white. So before COVID-19, it was pretty clear that every state said you had to be licensed in the state where the patient was at the time of the visit. So even if they had come to Seattle to see me and if they're back in Boise, I needed to be licensed in Idaho. But things have kind of gotten a little fuzzy with COVID, and a lot of the states have kind of temporarily waived those requirements. I have a table of all the various state laws on the next slide. But in general, you got to be in good standing in your home state, and you do need to at least give a kind of a written notification to that state's licensing body that you're going to be doing telemedicine. If you want to get an update on the latest information, the Federation of State Medical Boards has a good website, as well as the Center for Connected Health Policy. And there's some information there about nurses. Idaho and Montana is part of this multi-state compact. So I'll let you guys review this offline. You can see that a lot of the states have loosened the requirements. And I think the information in Idaho may not quite be up to date. I think that Idaho over the summer did make some changes around Medicaid and commercial insurance. So I apologize if that's not up to date. All right, so next I want to talk about the digital divide. And so there's a growing body of evidence that patients who have limited English proficiency or from lower socioeconomic status who are in rural locations are unable to access telemedicine at the same rates as patients in urban areas or English-speaking and insured. So the first bit of information is on the right there, comes from UCSF. And they looked at a variety of factors and broke it down pre-COVID and post-COVID. So they rolled out telemedicine very rapidly in March. And they found that before COVID, that the vast majority of patients visiting the general internal medicine clinic at UCSF, 40% were over 65, and that dropped to about 5 to 10% in the telemedicine era. Same thing with non-English speaking patients, that dropped way off. Medicare and Medicaid recipients were much less likely to use telemedicine, at least this spring. We have very similar data at Harborview and UW Medicine showing the same thing. So we also think about elderly patients. They don't have as much access to the internet. They're less likely to own smartphones. Those who are poor and low income, pretty good ownership of a smartphone, 71%, but not everyone really knows how to work it. So only 50%. And then some similar challenges in rural areas. So I'm just going to use some strategies for how we can help level out some of those health inequities. And this is from that same paper from UCSF from Nuri and colleagues. The first is just to be aware of this and be proactive about monitoring this and tracking it. And there's really probably 5 buckets that we need to pay attention to. The first is, do they have a device? And if they don't have a device, know that some insurance companies like Medicaid in Washington State have been giving out devices for free, and they're giving out smartphones. And some folks have kids that are getting online education, and they've gotten devices through their local school district, and maybe that's an opportunity to use that device when the kids aren't in school. Broadband's also an issue. You don't have to go to rural areas to have a real drop in coverage. And so that's more of a policy issue in our experience, and that has been a little bit of a harder issue to counteract. Literacy is a big issue, and this is where it might be able to work with your local library. Sometimes they teach folks how to access the internet, how to do email, things like that. English proficiency, English language, make sure your instructions are in their native language. And then a big issue is privacy. So Brian had a patient who he was trying to see who had not been seen for a while, and he wasn't sure if he was taking his ARTs, and he was joining from a shelter, and he could hear voices in the background and wasn't really sure this was the most private location. And so it was really kind of an ethical issue of should I continue with this? I really need to see him, but it's not the privacy that we would ask for. So be prepared for that. I think Brian was able to find a place in the shelter where he could be a little bit more private, but just be aware that some of our patients with HIV are having this challenge. There's other issues around digital literacy. I mentioned the local library, but I also might suggest we explore this idea of kiosks. So those are like private areas within maybe community centers or more homeless shelters, things like that. Those are some ideas being floated. Make sure you're removing the health system created barriers. We mentioned getting the instructions in other languages, but I do want folks to be aware of implicit bias. So one thing I've heard from my colleagues is, well, I don't offer telemedicine to my older patients because they just don't know how to work the technology. And so you're kind of prejudging people, not giving them the chance to even try it. And we have to really guard against that. And then finally, just advocate for policies and infrastructure that can bring broadband and equitable telemedicine access to everyone. In Washington State, we've been partnering with several legislators who are really coming at it from an education angle. So I think there's opportunities to work with those folks and improve our internet coverage across the state. So just wanted to leave you with a couple of resources similar to what we have at the AATC. There's something sponsored by HRSA called the TRCs, or Telehealth Resource Centers. This is a map showing where we are. So most of us are going to be in the Northwest Region Telehealth Resource Center, which is based in Salt Lake City. For those in the North Dakota and South Dakota, it's kind of upper mid-plains, and I think the HRSA website can direct you to the folks there. A couple other resources. I mentioned the Federation of State Medical Boards, and the last one is the Center for Telehealth and eHealth Law, which is a great group tracking a lot of the policy issues. So I think that'll wrap it up. I'll open up for questions, and I'll turn it over to Brian.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.